So this is, I think, a really interesting topic that I was assigned, and it was very thought-provoking. And I just thought, why not start with the bottom line up front? And I think all of you in this room who have spent, many of you, you've defined the field of plaque imaging. I think this remarkable group of people in this room, I think would view that, I hear people say, is it going to replace my intravascular imaging? And I would say to that, no. But it will make it better, and it will enrich who you image. And so let me just explain. So I wouldn't necessarily view this as directly competitive, although it may, in some instances, keep people from going directly to intravascular imaging. But I think it's importantly complementary because it does two things. And as Michelle already mentioned, is that number one, it allows us to identify and accurately identify patient and plaque risk in much of the same way that our intravascular tools have taught us to do so. We in the CT world have learned from all of you, and we continue to learn from all of you. In fact, how we define plaque risk has really been, the precedent has been set by what we've learned from intravascular imaging. And of course, as you heard, it's increasingly used in drug response studies, and I think we have a talk coming up on that. But I think importantly, when you think about clinical trial design, I think CT can change who we send to the cath lab in many cases, and maybe even be used as a standalone therapy as an endpoint in trials, and that is an area that's evolving over time, not currently quite there from an NHLBI, NIH, and FDA standpoint. But I think what we know is that it allows us to use the same science in an upstream population that previously we may not have been able to study, or if we did so, it would have been studied without plaque imaging, just based on clinical risk factors. But I think importantly, as I've mentioned this already, like all intracoronary imaging modalities, CT obviously has its own limitations. And again, I can't stress this enough. It really requires excellent image quality and attention to how you're acquiring images. And I think ultimately, knowledge of CT findings will make intravascular imaging better, because I mentioned earlier the game change or the significant practice change that is going on around the world. You're going to see more and more patients who come to your labs, whether it's in clinical trial standpoint or whether it's clinically, who have already had CT imaging. And here's my challenge: is that if you're in the cath lab, if you're an interventional cardiologist, I think you will be better by using the CT data that comes with your patient and integrating that into what you see. If we do intravascular imaging, it can complement, for example, some of the limitations of OCT and depth of penetration, or some of the limitations with calcium and IVUS. And those are things that I think, and even help with landmarks. And so CT, I think, will go there. But let's look at the data. And this was going back to 2013. This is a meta-analysis that we published way back in the day when this question was asked, and I said, gosh, I don't know, let's look at the literature, let's summarize the literature. Can CT be accurate to IVUS? And you can see these were very early studies, many on 16-slice scanners, very small studies. These are all expert centers, and these are all highly selected for exquisite image quality. But what we learned is that when you take very good CT images in the hands of experts, and you create meticulous multiplanar cross sections, that you can measure in a reasonably accurate way lumen area. You can also measure plaque area and plaque volumes, and some of the measurements that we're used to doing, such as minimal luminal area and plaque burden, can be assessed with CT, but again, requires high image quality and expertise. And of course, the challenge is, how do we do this on a routine basis, and can we do this on a routine basis? Well, you already saw this paper that I think advanced plaque analysis is actually can potentially change this whole paradigm. Instead of sitting in a dark room like some of us have done for studies and drawing circles around plaques and doing this every millimeter or so through a coronary tree, that the software can do this for us, and it can do it in a relatively accurate way. And this is data from, again, Dominic Day's group, where they looked at a host of both training cohorts and test cohorts, but some of those test cohorts were comparing against intravascular ultrasound, and you can see whether you do this versus manual plaque measurements versus intravascular ultrasounds, reasonable limits of agreement in relatively small data sets using advanced plaque analytical tools. And in fact, these plaque measurements, in fact, have prognostic data, as you've seen it on several of presentations today. At Elucid, we've done this as well. This is some work we've done. It's currently not been yet published, was presented at TCT last year, comparing, this happens to be the Elucid software, working with Christos Barantis' group, and showing that if you just look in 100 heavily diseased vessels, things like total atheroma volume and percent atheroma volume are reasonably similar, and this is certainly work that we're going to continue to refine towards publication. So this is a slide from Greg Stone, and I think the question is, of course, We've learned so much from the work that's been done by Dr. Stone and others of the predictive value at the plaque level of invasive imaging. And so you can see a variety of these and some of the adjusted hazard ratios related. The question is, can CTA replicate this? And I think we've learned that, in fact, measurements of plaque burden and minimal luminal area, that I think we're all pretty confident that CT can do this if done correctly with reasonable image quality. What we're learning is, in fact, that there are surrogates of high lipid content plaque based on years, and we are learning what those look like, and they're not surprising at all, right? These are lesions with high degrees of non-calcified plaque, particularly low attenuation plaque. And these publications are a few small publications just for the sake of time I won't go through. The real challenge has been, and we often get asked, is can CT identify the thin cap fibroatheroma? Because we know it's the thin cap fibroatheroma, particularly when associated with large plaques, as well as plaques that have small minimal luminal areas that have the highest event rates. And I think this is a really important study. We learned from OCT, this is 3-vessel OCT, that in patients where they looked at non-obstructive, non-culprit lesions and followed them for events, and in looking at lesion-specific and patient-specific events. And again, it is the combination of thin cap fibroatheroma and low MLA. And I think CT can certainly give us the low MLA, but can it identify the thin cap fibroatheroma? And that's been the challenge, because we know the spatial resolution of CT is not there to identify the thin cap or even measure thin cap thickness. So how well do these high-risk plaque features do in identifying thin cap fibroatheromas? Well, Dr. Narula had taught us for the first time that even in patients who did not have obstructive coronary disease, that these 2 feature plaques were remarkably predictive of patients who have events. Are these thin cap fibroatheromas? Well, what we've learned is that many of them, in fact, most of them probably are. This is some early work back from 2015, looking at 68 plaques in 45 patients. They classified high-risk plaques on CTA by a very experienced group using the standard definitions that you've heard today. And they looked at OCT. And what they found is, in fact, if you look at these thin cap fibroatheromas comprised about 24 of the 68 plaques, they also looked at macrophage infiltration. If you look at TICVAs with macrophage infiltration, the majority of these plaques had at least 2 adverse plaque features. And again, when you look at this in a multivariate way, those 2 were positive remodeling and low attenuation plaque. Others were predictive as well, such as stenosis, mildly predictive, remodeling and attenuation values. But those 2 seem to be the most predictive of finding thin cap fibroatheromas. And I think that's why those have stood this test of time in identifying risk. We know, of course, there are limitations. Calcium in IVUS can limit your ability to measure truly the vessel dimensions or plaque around calcium or behind calcium. These are overcome with other imaging modalities, but of course with OCT, your limited penetration it really limits you. And we know that these limitations, you all in the room know better than me, and you use these every day. And so in conclusion, I think no single imaging modality can reliably detect all critical lesions of high-risk plaque. I think coronary CT is likely the optimal imaging modality in patients, particularly those not already heading to the cath lab. If you get good image quality, our current definitions of high-risk plaque are reasonable surrogates. They're not perfect surrogates for thin cap fibroatheromas, but I think you can think about how we would enrich future trials using CT to assess response to therapy or assess novel therapies. I think CT is probably emerging as something you can do, and you'll hear a talk about how it's already being used in that way for serial response to therapy. But I think something that does not get talked about, and I mentioned this earlier, is you have to account for differences in technique, and that does not get enough press, does not get enough attention. Your iterative reconstruction settings, your KVP settings, how you use even photon counting CT, all matter on how these software perform. But I think this is what's coming. Photon counting CT overcomes a lot of limitations that you heard from Dr. Barantas, and it's going to be an exciting area. And so I just wait till you see those images if you haven't already. Thank you.
Thanks very much, Todd. A fantastic talk. Bridging